get to that.
You all have a lot
Sure.
to do.
Good morning, and welcome to this oversight hearing for fiscal year 2017 budget for the Indian Health Service. Funding for Indian country has been a nonpartisan priority of the subcommittee for many years now. Working together, we've grown funding for American Indian and Alaska Native programs a greater amount and at a faster rate than any other programs in the appropriations bill. As a result, contract support costs are now fully funded, freeing up operation funds for operations and affording tribes the capacity to run additional programs rather than relying on the federal government to do it for them. Funds to meet extraordinary medical costs to victims of disasters or catastrophic illness, which used to run out in the middle of the year and thus spawn the common refrain in Indian country, "Don't get sick after June." And now finally in FY17 estimated to last the entire year. More children receiving proper dental care, more teens are receiving the help and support they need to battle substance abuse and suicide. More providers are being recruited because we've been helping to pay back their student loans. More new care facilities are opening their doors each year. The list of accomplishments go on, and we're deeply proud of our work. But we also recognize that we still have a long way to go before health disparities in American Indian and Alaska Native population compared to the nation as a whole become a thing of the past. I hope that today's hearing will help highlight the measurable differences that reflect funding increases have made. As a subcommittee, we need to be able to communicate to our colleagues in Congress that the sacrifices we make elsewhere in this appropriation bill in order to increase funding for Indian country is actually saving lives. Saving more lives, however, is not simply a function of more money. The Indian Health Service is battling a management crisis in the Great Plains area, for example. The crisis has reached a new low point recently when the Centers for Medicare and Medicaid Services, CMS, terminated its agreement with Winnebago Indian, Omaha. After Denver's win, I should know that, Omaha Winnebago Indian Hospital, because the conditions at the hospital posed an immediate jeopardy to the health and safety of patients. Just a few months later, CMS threatened to do the same at 2 additional Indian Health Service hospitals in the Great Plains area. All 3 hospitals are directly run by the Indian Health Service rather than by the tribes. And all 3 remain open for business under intense management scrutiny. That said, it's not my wish to focus today on hearing on the crisis in the Great Plains. The Senate Committee on Indian Affairs has already held 1 hearing on the matter, and I doubt it will be the last. Also, I do not wish to imply that funding and management are unrelated. We all know that it takes money to hire and retain good people. My point is this: when the Indian Health Service struggles with management and accountability, the subcommittee struggles even more to find the money, the offsets, and the votes to fund increases for the Indian Health Service. The President's FY17 budget will particularly challenging. The Bipartisan Budget Act of 2015 increases FY17 discretionary budget authority by less than 0.1%. And yet the President is proposing an 8%, $377 million increase for IHS without any realistic offsets elsewhere in the budget. Of the proposed increase, $241 million is just to keep pace with tribal and federal pay costs, contract support costs, medical inflation, and population growth in order just to maintain current levels of service. Program increases developed in close consultation with tribal leaders, which are necessary to staff newly constructed facilities and to make any real progress to decrease the health disparities of American Indians and Alaska Natives compared to the nation as a whole, or an additional $136 million. Welcome. With us today from the Indian Health Service to get into the details and answer questions, our Principal Director and current Acting Director, Mr. Robert McSwain. That's good timing. You came right to the time I was going to introduce you. And his second in command, Deputy Director Mary Smith. Welcome, Mr. McSwain, and welcome aboard, Ms. Smith, and look forward to your testimony today. But before opening statement, I'd like to ask our distinguished Ranking Member, Ms. McCollum, for any opening remarks.
Thank you, Mr. Chairman. I'd also like to join you in welcoming our witnesses here today, and I look forward to hearing their testimony. Funding for the Indian Health Services has been an area of broad nonpartisan support. I would even make that stronger than bipartisan cooperation in the past several years. However, last year's events in the Great Plains region, as the chairman pointed out, makes it clear there's more to be done and can create an obstacle in us doing more. We have a moral and legal responsibility to provide health care for Native Americans, and when we fall short, it's not just a violation of treaty agreements that we hold with Native Americans, but it's a violation of a trust that we share. The failings at Omaha, Winnebago, and Rosebud are alarming, just alarming. And despite the increase in resources the subcommittee has provided, it's clear that resources alone will not solve all these problems. We also need permanent employees that have the skills needed to serve the region and a culture that fosters excellence in patient care. I'm hopeful that the top-to-bottom audits that the service is undertaking in the region will provide the assurances that these incidences will not happen again and the guidance necessary to improve the entire Indian Health Service. Fiscal year 2017, the Indian Health budget includes $1.5 billion in discretionary funding and $377 million increase over FY 2015 enacted level. Much of that increase, $159 million, would be used to cover increases in the cost of providing the same level of service. $82 million would go towards increased contract support costs, and $103 million would expand and strengthen the services program. And I am pleased to see the budget request includes $12 million increase in Indian Facilities contract line for construction of new quarters for Indian Health Service staff. The problems at the Great Plains region have made it clear recruiting and retaining permanent staff must be a priority for the service. The quarter's budget increase will help the agency bring more permanent staff on board in these very isolated locations. It is clear that there is a mental health crisis in Indian country, and Pine Ridge Indian Health Service documented 18 cases of suicide and 308 cases of attempted suicide last year, in that's nearly one case per day. Suicide is the second leading cause of death for Native American youth aged 10 to 34. And I am pleased that the budget request includes more than $40 million in new resources to tackle this problem. However, the solution in the mental health crisis alone does not come from health care alone. So I'm interested to hear how the Indian Health Service is working with other agencies to ensure that Native Americans have the access to quality education and housing, as well as economic opportunity. The administration's Generation Indigenous initiative seeks to coordinate its efforts in Indian country, and I'm interested in learning more about Indian Health Service's role in these efforts and how tribal members can participate in the process. And finally, I am concerned about the lack of dedicated resources in the budget to combat opiate addiction. In addition to treating addiction, we must develop the tools in pain management to ensure that patients in chronic pain do not abuse their medication later. And I want to stress again, I think it is wonderful what the President has put in for drug interdiction for youth. But in talking to youth recently in my office over the past 3 weeks, they're talking about parents and people over the age of 34 that they're in contact with that are either abusers or trying to quit the problem. So we need to look at this as a family, as a whole nation problem. Mr. Chairman, I want to thank you for holding this hearing today, and I look forward to working with you and Chairman Cole and everyone on this committee on these important issues and doing our part to build tribal healthy communities, making the whole United States healthier. Thank you, Mr. Chair. I yield back.
Thank you. Mr. McSwain, you're recognized for your opening statement.
Mr. Chairman and members of the committee, first of all, let me just apologize deeply for being late. It's not like me to do this, and I know I didn't start off on a good foot, and I just want to, on behalf of the agency, beg your indulgence. I am, as pointed out, I'm the Principal Deputy Director of the Indian Health Service, and accompanying me today is Mary Smith, the Deputy Director, and also Elizabeth Fowler, Deputy Director for Management Operations, and Mr. Gary Hartz, Director of the Office of Environmental Health. I think we've got the team here to be able to answer any and all questions that the committee has about our budget request. I'm pleased to present provide testimony of the President's proposed 2017 budget for the Indian Health Service, which will allow us to continue to make a difference in addressing our agency mission to raise the physical, mental, social, and spiritual health of American Indian Alaska Natives to the highest level. The 2017 President's budget proposes to increase the total IHS program to $6.6 billion, which will add $402 million to the FY 2016 enacted level, and if appropriated, this funding level would represent a 53% increase in funding for the IHS since 2008. And I want to thank the committee and the Congress for that support over the last few years. The overall funding increases proposed in the President's budget are consistent with tribal priorities. We consult with the tribes on what we want to ask, and so this represents their asks as well as the administration. And these will continue to address longstanding health disparities amongst American Indian Alaska Natives compared to other Americans, and specific investments including expanding behavioral health and mental health services, improving health care quality, capacity, and workforce, supporting self-determination by fully funding contract support costs of tribes who manage their own programs, and ensuring increased health care access through addressing critical health care facilities infrastructure needs. As you will see, I mean, we've had a great series of increases that has enabled us to replace facilities that are average 33 years old per facility. The President's budget includes funding for full, what we refer to as current services, full pay act. It's pay costs, inflation, and pop growth, because the population does grow, and we respect that, and we must maintain pace. And these are critical for just simply maintaining the budgets of IHS and tribal hospitals, clinics, and other programs to current levels. That gives us a starting point. The budget also includes increases of $49 million, of which $46 million will be focused on critical behavioral health services, including Gen-I, certainly, and suicide prevention projects, and also the integration of medical and behavioral health into our system so that there's a behavioral health primary care integration. It's also continued to the whole of behavioral health in tribal communities between medical and behavioral health and tribal community organizations. And we found that there's several programs out there that are granted by other agencies. It's a matter of us working together and to integrate those into a complete program for those tribal communities. And we're implementing the budget is to help us implement Zero Suicide Initiative. And the Zero Suicide Initiative is simply put, we run a healthcare system, and the healthcare systems means that our staff are trained, not only our staff, but the tribal programs that are operated, that we are aware of high-risk people coming through the system, so that there are not just behavioral health people in the facility, but all the providers are trained to be aware of those indicators that would show that people are at risk. And so we don't just simply have them come in for their usual medical checkup, but we're also observing. So we're training for purposes of a zero suicide. A youth pilot project, something that is the tribes have been asking for years, and that is aftercare. So we have these nice youth regional treatment centers. They go and they get treated, then they return. What about aftercare? So we're making an investment for aftercare. Domestic violence prevention to expand the numbers of grants to 30 additional ITU organizations, and certainly funding to expand the catastrophic health emergency fund and for a bit for urban programs as well, because Indian people do find themselves in urban programs, and that's a major priority for us. Improving the quality of health care in the Indian health system is a primary objective of this budget, and it goes to the point of investing in health information. Data drives our decisions, and we want a better data system that will help us do that. We have the electronic health record, and we can talk more about that as we go on, as well as we have moving towards all 27 hospitals under a hospital consortium that is based in quality, with quality measures. The whole notion of the infrastructure for new facilities, and we've got things for addressing 5 newly constructed facilities, for tribal clinic leases and maintenance costs specific to where tribal space is ineligible for maintenance and repair, and some additional money to begin to address the backlog. As you all know, our backlog in basic maintenance and repairs around $473 million. So we have made an investment there to reduce that as well. In addition, this budget will enable us to complete the Phoenix Indian Medical Center Ambulatory Care Center and begin the design of the White River Hospital, continue construction of the Rapid City Health Center, and to begin the construction of the Dilcon Alternative Rural Health Center on the Navajo, and to fund replacement, additional, and then, of course, as mentioned by Member McCallum, that we have a new venture in addressing the need for quarters. Staffing quarters is critical in some of our remote locations, and we've put an investment there to begin the process. We're still looking at where do we need to go with this, and we'll do that. Supporting self-determination. Again, full payment. I wanted to simply thank the committee for urging us in that direction, and we're there, and I think we've got a lot of good things to report on that front. We've got a couple legislative proposals that I want. One of them is to address the very definitions of Indian in the Affordable Care Act. We've got several definitions, and so depending on how it's defined is how the law gets implemented. We'd like to see that addressed in our proposal. And finally, on the legislative proposals, another one is the special diabetes program. A very successful program for us in terms of a chronic care model, and we've got some data that we can share with you. Certainly shows where we're beginning to slow the progress of diabetes in Indian country, particularly amongst the youth. And I know that you've mentioned it, and we can talk about it, but we're looking very closely at the Great Plains hospitals. And in this regard, a real focus on retention of recruitment and retention of providers, certainly the housing issue, working more closely with our sister agency, the Centers for Medicaid and Medicare Services, and what their findings are. I can tell you on the record, what they have found is unacceptable to us, and certainly has drawn the attention of Secretary Burwell, and she's put in place an ability to respond, not only to the department, but assist in the Indian Health Service in addressing these issues. I want to close by emphasizing that the challenges we face, I know that working together in partnership with Indian country and the Congress, we can improve our agency to better serve tribal communities. And I appreciate all your efforts to provide us the best possible health care services to the people we serve, and in helping to ensure a healthier future for the American Indians and Alaska Natives. With that, I close, and the team will answer any questions that you might have.
Thank you, Mr. McSwain. Mr. Cole will start off the question.
Thank you very much, Mr. Chairman, and let me just state publicly, I want to thank you and our ranking member for all you've done over the last few years in this area, in your respective positions now, but just even before that, when you were simply members of the committee. It's made a big difference in a lot of lives, and I want to congratulate the administration, too, in this regard. This has been a great area of bipartisan cooperation, and where I think the resources that have been placed there have broadly, made things better, have saved lives. So there's a lot to be proud of here, but as you pointed out in your opening remarks, there's always things to be concerned about. I'm going to have to leave literally after my question and your answer, Director Burwell, because I'm going to chair a hearing with Secretary Burwell at 10 o'clock, so I got to go do that, and I'm sure we will discuss this issue in that hearing. So I do want to give you an opportunity to talk at length on this Great Plains CMS issue. I'm very concerned and troubled when we have 3 different facilities. It suggests something systemic is a problem. And so, one, I'd like to know specifically what are the findings, and what has been done to correct them for those 3 facilities. And then, what you're doing system-wide to make sure this isn't 3 needles in a haystack that suggests there's more needles. Last point, if you would touch on it, have you seen any difference between the facility? Would we find the same thing in tribally operated facilities as we're finding in these? Is there any disparity in ratio? And again, if so, why? Or do you think these issues that we found in these 3 facilities we'd find if tribal facilities were looked at? Is this random? Again, I want your thoughts on that, because I do have and I will say up front, I tend to have a bias in favor of tribes basically, joint venturing and operating their own facilities. Nobody holds you accountable. It's very like your own people do. And I know in our tribe, when we took over the operation of our facilities, or began to in the 1970s, made an enormous difference. Almost immediately, we saw wait times come down very dramatically, because if somebody was sitting there waiting too long, they would simply call a tribal legislative official, and you could get your fingers around their neck pretty fast. So it was just responsive. And plus, on top of that, we developed people in our own tribe, gave them opportunities to acquire professional skills, manage big budgets, to do things, and frankly, they've moved on into other directions now. It gave us a cadre of really trained and talented people. So it's an area that I just want to get your thoughts on that, on the contrast between, again, IHS facilities and tribally operated facilities.
Thank you for that question, Congressman Cole. There are very important distinctions, and one of those is on the federal side, we're governed by rules, regulations, pay systems, and tribes have the ability to be flexible. They're not bound by the pay schedules, so they can be very competitive in doing so, as well as the regulations that govern how facilities, but they're also governed by certainly the same rules we are when it comes to certification by the Centers for Medicaid and Medicare Services. We have not had any citations for tribal facilities, and clearly I think a lot of that has to do with when the tribes operate, they take pride in managing it very literally. I mean, of course, as you mentioned, when there's a complaint by a tribal member, they know where to go. I mean, it's if they're running it, they go to their council. And when we're running it, as we do with 27 hospitals and some 200 plus health centers across the country, they're staffed, and we run according to federal regulations and federal requirements. And the biggest challenge that and this segues into the challenges I'm seeing in the Great Plains area. We're addressing currently the current findings by CMS in those 3 facilities. And they center around having trained, qualified providers. And we are trying to carry out the mission with a combination of contractors, a heavy contract load. So if we can't hire and permanent staff, and I think it was mentioned earlier that the biggest solution is to have permanent staff there. But it's a challenge. Many of these locations are very remote, very isolated, and not only is it a housing issue, which we're struggling with, and we put forward the notion, and let's face it, I've talked to many of the tribal leaders, and they have a housing program. They don't have enough housing just for their own members. Yeah. There are 20 people in a house. As I talked to one tribal leader, he says, I can't give you a house to provide for staff. I need those homes for my own members. I'll certainly work with you on space and so forth if you can build them. Ergo, our requests for additional housing. Housing is a real challenge, and we found that out when we were beginning to address the issue with Pine Ridge suicides. We could get healthcare workers up there, but they had to drive 60 to 70 miles. Yeah. And they weren't going to stay there. And so we immediately began putting in place some temporary facilities on the short run, and then some modulars. So those are the challenges in the Great Plains area, which are probably not shared other places in the system.
Yeah, and let me just make this point, and then I'll yield back my time that the chairman's been so generous with. I think that's true. I've been to the Rosebud. I think Ms. McCollum and I were on the same trip there and seen the facilities and seen the challenges in terms of the housing. And I want to commend you for doing it. I also want to, while I'm very concerned about this, I want you to know I see a lot of these things as functions of a system that's been historically underfunded. I don't blame this on the Indian Health Service or what have you. I have some idea of the scope of what you've had to deal with literally for generations. And it's only in the last few years, honestly, that we've begun to give you the resources to make the difference that you are making. But I would commend you to keep really look at this, because as the chairman suggests, this is the sort of thing that does make it difficult for us to convince our colleagues to continue to fund the service, which I think is indispensable. And while I have a bias towards tribes operating their own, that's a tribal choice. I mean, I respect tribes that choose to do it in a different manner, and they're best situated to make decisions for themselves as to which would work better for them. It shouldn't be imposed on them from up here. So just thank you for your good work, and look forward to working with you. Look forward to working with my friend, the chairman, the ranking member, and the other members of this committee to see if we can continue to build on the progress of the last few years.
Yep.
Thank you, Mr. Chairman.
Thank you. Ms. McCollum.
Just follow up on that, and then for a second, it's not just housing in the Great Plains area. It's housing, it's schools for the employees to send their children to, and the chairman and I and the members of the committee are working on improving the situation of schools, being able to recruit and retain teachers who also need housing. If you're a person who comes to work at one of these facilities, or even an educational facility, it's having daycare, high-quality daycare available. So this is a whole of nation challenge, and I know President Obama has made it a priority to have all the agencies sit down, work together on these problems, because you don't address a whole problem just by siloing it and checking off a box and saying we took care of it. So I appreciate that, and I think the committee's gonna ask at some point, what are we doing throughout the agencies to help you address this problem or other problems. But this also goes to a whole of family issue. As I mentioned in my statement, and you also touched on, there's a mental health crisis in Indian country, and Native youth have been particularly hard hit. And the budget request does have additional funding for tribal youth around mental and behavioral issues. And we could talk about this for hours. So I'm just going to lay out a few questions, and then if you could give us a general observation and then get back more fully to the staff. So I'm going to ask you to describe your requests and how these initiatives are really going to improve mental health outcomes for youth. Nationally, not only in tribal areas, but nationally, there is a huge shortage for capacity for youth with psychiatric issues, mental health issues. I want to know how the agency is going to, work to help youth in this way. And let me just describe what I've seen in Indian country. Should a youth and their family reach out, they are sent to a regional treatment facility, which can be hours and hours away from a family. When a youth is having a challenge, that usually means quite often that the family is having a challenge, or the family isn't having a challenge, the family needs the supports put in place for when that youth comes home, which usually means family counseling and addressing other issues or addressing other maybe substance abuse problems in the family, so the whole family is being treated. I hear that directly from youth in my office. So I was in Red Lake, and they're seeing their out-of-placement go through the roof, in part because of substance abuse in the family, which affects a child, or a child is living with a grandparent who needs more tools in their toolbox when the child comes home from treatment. So I want to know what you're doing to bring this closer to home. Building a new regional treatment facility is a good step, but it is not the only step. And if that's our only focus, we will have failed these children, and we will have another generation suffering from post-traumatic stress. So could you kind of give us an overbroad description of what you're doing to address the whole issue, not just, and I'm pleased that you're asking for a new regional treatment facility, but that's not the full solution, and then follow up with staff in greater detail.
Thank you for that question, Congressman McCollum. This is a real challenge, obviously, in many of our communities, and the biggest challenge is the available resources and the available access points for behavioral health and mental health in the communities. What we're learning is as we work with hand in hand with the tribes. And we're doing that, and I hate to go back to Pine Ridge as a prime example, because we focused on Pine Ridge a year ago when they had 18 suicides, and I'm happy to continue to hold my breath because we've made it through the winter months now with no suicide since November, and that is where I think a lot of it has to do with attention. Providing the kinds of, and I think your other comment about the Indian Health Service cannot do it alone. We recognize that, and I want to thank Secretary Burwell and Deputy Secretary Wakefield for literally getting us all together and saying, okay, here all the agencies in the department have a role to play. And then they're reaching out beyond that. Clearly, the Secretary is reaching out to other departments that could help. We're going to work all together to begin to address this issue. SAMHSA's a good partner. They're providing resources to the communities, the tribes, and their programs. It's our goal is to ensure that we link with them with our provision of care to their community action groups. The agreement we have, and you mentioned the schools, is that we've entered into an agreement with the BIE to have mental health workers in the schools. If they give us just a little bit of space. I know space is hard, is hard, but we can have someone there that can begin to counsel the youth in the schools and make them available to the communities. And this is we're building a model that and if what we're doing is in fact working, then we'll need to do more of that in other places, because as I've traveled around the country. With listening sessions in 12 areas last year, it's not just the Great Plains area. It's the Navajo, it's the Northwest, it's Alaska, it's California, it's the Arizona folks. I mean, everyone is very concerned about their youth and what's available. And you're right about even we can build as many YRTCs, or Youth Regional Treatment Centers, but again, someone has to get them there and then return them, which is what we're finding out, and we've proposed that in the budget. We want to do something about aftercare, and so that there's more watching of the kids when they return home, and providing those safe zones. I think there was a hearing that was held last year about the cost of suicides, and one witness said, schools are a safe zone. So this is because of families and the struggles at home. So all of this comes together, and I just want to say that what we're learning in Pine Ridge as a model, we can replicate. But you're right about we can't. There's a big debate going on presently about trying to build another facility in a far location, and whether or not that's the best thing to do, because the families want to be local, and so then the challenge is, where do we put it locally in a place like, and I know that with the Great Plains area, we're testing with a strategic plan, and I'll ask Mary Smith to respond to that, because I think it's an important thing what we're doing. We're doing a lot of immediate response, but then the long term, how do we sustain it and keep it going? If you don't mind, I'd like to have Ms. Smith respond to the strategic plan layout, if you would, please.
Okay. Well, thank you. Hi, I'm Mary Smith. I'm Deputy Director of the Indian Health Service. With respect to, I know it was mentioned the challenges in the Great Plains, so we are certainly addressing immediate things that were cited by CMS and trying to work to solve the immediate problems. But one of the other things that's kind of been mentioned at this hearing is some of the systemic challenges that we have with staffing, housing, and lack of access to schools and job opportunities for spouses and things like that. So we are actually engaging in kind of a strategic framework effort to look at some of these core issues like staffing, housing, and expanding the use of telemedicine to try to strategically think about these things. We're looking at both short-term, intermediate-term, and long-term proposals. Of course, we can't do this without our tribal partners and you all. So we are gathering data. We hope that this will be a data-driven process. And in the very near term, we will be reaching out to our tribal partners and you all to start to think through these problems on how we can address them both short-term and longer term.
Thank you. Let me ask a question regarding your testimony. As you mentioned, our appropriations have increased approximately 43% since 2008, and substantial investments to impact the quantity, of course, but the quality of health care provided to American Indians and Alaskans. What do you consider to be some of the most significant improvements? And how are you mentioned measuring, how do you measure that progress?
I think our most significant has been in the areas, certainly in our ability to purchase care. We've had a rather significant increase in the purchase referred care account, contract health service. In some areas, and not all areas, we are struggling with some areas, and there's some of them are still on priority one, life and limb, but a number of the areas have begun to see where they can get down into priorities 3, 4, and 5, or 4, not 5, but 4. 5 is not allowed, certainly because it's cosmetic surgery, but 4 certainly is one where if you can get down into 3 and 4, and you get past preventive health, you're past the life and limb, I think our biggest success has been in purchase referred care and our ability, because we, as you know, over the years, we have converted a number of hospitals to health centers. And by converting them to health centers means we buy the care. We buy the secondary care that we need to provide the full comprehensive care that we provide to our American Indian Alaska Native patients. So there's been a shift in that regard and will continue to be so. But that's one major piece. And the other one is facilities. I mean, I recall 15 years ago, we had absolutely not much support for facilities, and we've actually been moving down that road in terms of finishing a lot of facilities on that priority list, and joint ventures. The joint venture program has been real robust, and so if the tribe, we partner with the tribe will build a facility and we'll staff it, and that's another way to provide more quality access to care with some of these facilities that are being built. So those are two examples in addition to behavioral health. I mean, as you know, the old days of, and I've been around the system for a few years, and our experience in the older days was we could take care of by just providing safe water and sanitation. We could have an impact, a positive impact on infant mortality. Today, we're challenged by behavioral issues, and behavioral issues are in the community, which requires us to work closely with tribes. But the investments we're making in behavioral health now are as you can see in our budget proposal for this year, the President's budget proposal for 17, is really beginning to focus on behavioral health issues.
On the behavioral health issue, we had some of these native institutions. For instance, I have one near my district in California, the old Sherman Indian Institute. Right. And it seems that in the past, many folks sent their children out to these schools for education. It was somewhat controversial. I don't dig up the history of that. But it seems lately, many times, it seems that they're sending young people to these outer areas, away from their homes, to get away from their homes primarily, to fix maybe some behavioral issue or some family issue that they can't deal with on their own reservation. Are these facilities working, or is it better to have, as you say, that these centers closer to home, closer to their families? So, how do you look at that?
To the extent we can, and I think you're referring to the Southern California Youth Regional Treatment Center that's being constructed near Hemet.
Right.
That facility we chose the site based upon the tribes getting together. Where would they like to see that site? Where is it most accessible, and where can it be? And they selected that site. Yeah. The same went for Northern California. The tribes got together and they selected a site. And the idea behind that is in fact, I think Mr. Hart's just given me some examples. As soon as we're done with these, sure. We will invite you to. I think we've had a conversation about inviting you to. This is the one at Hemet in Southern California. But it's where we put them, and I think in every case recently has been the tribes participating, and there was a lot of testimony at the groundbreaking with some kids that had been shipped away. One of them came back to say that the program was great. Just wished he wasn't sitting in Salt Lake City. Would prefer to be closer to home. And so those are the testimonies that we're getting for having those sites closer in. And so I think that that plus other options. I mean, it's not just YRTCs, but we've partnered with the Boys and Girls Clubs that would work on the reservations and help us put together meaningful activities for kids on the reservations. And so those are things that that we're doing in this front.
Yeah. Well, I look forward to attending the ribbon cutting. So,
Yes, it's.
Ms. Pingree.
Thank you, Mr. Chair. Thank you for your work and for your presentation here today. I want to just talk briefly to you about the opioid epidemic. It seems like virtually every committee I sit on has had to have a hearing on opioid issues, and it's certainly a challenge that all of us face in our states across the country. And people see it, really at a crisis level, but it's certainly a big challenge within the tribe as well. I come from the state of Maine, and the Penobscot Nation is one of the 8 tribes throughout Indian country to receive funding for a grant. It was the Department of Justice Coordinated Tribal Assistance Program. They were able to have a healing wellness court. That CTAS grant will end, and that will be too bad because that's been a real asset in terms of getting people through the court system and right into treatment. That also is that lack of the grant is going to be exacerbated by the fact that there's insufficient facilities to treat people with the opioid crisis. In our state, often to find an inpatient bed, people have to travel as far away as North Carolina, and in so many of these issues, we've been talking about the importance of being close to your community, to your family. So I know that the substance abuse budget is, the request is for an increase from $114 million to $140, and I know that would be very helpful. But I guess I'd like to hear you talk a little bit about, will any of those funds that you're requesting support increased access to inpatient treatment for adults? And can you talk a little bit about the current status for inpatient care for substance abuse treatment and how budget increases to contract health services might help in this area?
Excellent question. And the whole opioid area is as a healthcare delivery system. It's one that I'd certainly wish Dr. Susan Carroll was here, the Chief Medical Officer, because she has been very providing leadership for the whole of medication controls and pain management, and we tend to have it in pain management occurring in our facilities. Is that we tend to palliate someone who's in pain and then wind up having a prescription drug problem, namely with opioids, and so. As part of a larger issue from the certainly the president and the secretary, is a major push on opioid abuse, and we are as a system addressing it that way. Now, your question about hospitalization, it doesn't necessarily rise unless they're in real deep trouble. Then they will be referred under the PRC program to a facility for purposes of either detox or certainly for attention. So as a system, we're very, very conscious of our pain management program. In fact, we've published a policy and provided ongoing training with our providers about how to appropriately administer pain management medications, as certainly in the area of opioids. I know that what we're doing and I having conversations with tribal leaders about not only the quick step between opioids coming out of our healthcare system to heroin abuse. It's the transition, because it's if they can't get their their opioids, Oxycontins and such from our healthcare delivery system, and that's an area for us to really been working on very carefully, and we have some campaigns of teaching, and certainly of our providers, but also of communicating with the tribes about the need for that. There isn't a tribal meeting I haven't had where a tribal leader has said, "I've got a real problem in my area, and you could help by addressing this." So as a system, we're responding, and I know on the tribal side, on the tribal programs, they're also responding. The ones that are totally run by tribes, such as Alaska and California, for example.
And I appreciate that you're taking that comprehensive look, because I think you're right. In most communities, people have been concerned about overprescribing of pain medication. And then certainly in many of the areas of the country, like we have in New England, as physicians tighten up on pain medications, but you have a lot of people who are previously addicted, less expensive heroin moves right in,
Yes.
and that's really become a challenging issue, and it certainly is in my state, and I know in a lot of other places. So, having a physician involved in that role, but then figuring out what to do. And as we all know, these are very powerful addictions. So for many people, the only option that will be helpful is going to be an inpatient recovery program. It's good that doctors are better at dealing with the issue, or that there's some medication-assisted treatment. But in the end, I know we'll continue to ask you that question about how, in a state like mine that doesn't have sufficient facilities, do we manage that? And if there's an increase in your budget, is there a way to have more inpatient treatment so, in our state, people don't have to travel so far away or wait so long for beds? Because, again, as you know, there's sometimes a moment that you can get someone into treatment, and if they have to wait a long time, then, it's not a possibility a month later, or sometimes they're not with us a month later. We certainly hear from our tribal leaders that that's a huge challenge. So, hopefully there will be an increase in your budget, and hopefully we'll see, and others will see, that there's better access. So thank you, Mr.
Yes,
Chair.
I just want to add one other thing, as you were mentioning, Congresswoman Pingree, was the fact that we've also partnered with the Bureau of Indian Affairs, particularly their law enforcement individuals. We've actually entered into an MOA that is going to address not only training for the use of naloxone because of opioid overdose, is that the real for them to be able to use the naloxone to in fact ensure that they don't expire and from an overdose, and so that training is going on across all the reservations that have law enforcement individuals. Not only the BIA law enforcement, but those tribes that have their own law enforcement, like Cherokee.
That's great. That's very important too. Thank you.
Okay, thank you. Mr. Simpson.
Thank you, Mr. Chairman. It's an interesting discussion that we have on that, because it is a real problem with prescription drug overdoses and those types of things. The challenge is, having been a medical professional in the dental field, as a doctor, it is hard when someone comes into you in what appears to be severe pain to determine, to say, no, you're not in pain. And how do you deal with that? And trying to establish whether someone is there because they just want access to drugs, or if they really do have pain, is a challenging thing for doctors to try to deal with. But it is a real problem, and something that we've got to find a way to work around and have people more conscious of it and so forth. So we have a tendency to just want to say, don't overprescribe, and that'll solve the problem. It's not nearly as easy, and I'm not suggesting that you're saying that, but
No, I'm sure.
it's not as easy as some people sometimes think it is. You mentioned joint ventures, where the tribes will build facilities and we will staff them. Do we have any facilities that have been built that we have not staffed, that are planned to be staffed because of lack of funding?
None whatsoever, because part of the, as you know, the joint venture program is that when we go through the process, and Mr. Hartz can provide some lengthy experience about the joint venture program, what basically happens is it's a competitive process, very competitive, and the idea behind it is the tribe will build a facility. They'll have a conversation with us so that we can match up our program, our requirements for staffing in terms of their population, et cetera. But they will build a facility, and they will find the resources necessary to build that facility. And we commit in an agreement that at some point that they're going to open, we will ask for staffing funds for staffing and operating that facility. And so that agreement means that we have not built any joint ventures where we have not committed to providing the staff.
So we haven't had instances where the tribes get out ahead of our ability to staff them? I mean, several years ago when we were looking at this, we found that there were facilities that were built, particularly tribes that had successful casinos and stuff and had the extra money, went out and built them, and then are coming to us saying, hey, we need to get this staffed, and apparently the department doesn't have the resources, not only in the health area, but also in the law enforcement area to staff those facilities. But we've addressed that problem.
Oh, on the Indian Health Service side, and I know where you're going with, for example, there were several detention centers that were built with no program in mind.
Right.
And they've come to us and said, oh, can you put your behavioral health program in that detention center? But for purposes of healthcare delivery, like a health center or a hospital, if it's a joint venture, we have a conversation with them. They apply for it, and they're approved for it. We go through a two-step process. They give us their ideas. We review them. We move to the second level, with which they have a business plan. But at the end, we will reach agreement with them. And currently, we had the last go-around, we had 13 that actually qualified for consideration. We started out with 3 at the top that we've agreed, and they're on schedule, and they'll be reflected in upcoming budgets. And because the other ones were small in terms of staffing requirements, we went ahead and did all 7.
Okay.
We added 4. And the idea behind it, because so it's a combination now in terms of facilities mean access to care. The tribes have elected to build if they've got the wherewithal, and you mentioned casinos. The tribes can build them, and we'll partner with them and staff it with staff. And of course, and this new one, we haven't done this for a while, is that we have a proposal for small ambulatory. Because, and again, in the interest of providing access to care, we've had, that was a very successful program. They can leverage the funds that we give them with other agencies and matching. But the idea is they can have a facility that they can then have available for access to care on their reservations or in their communities. A small, it's usually a health station, and you'll see that in our budget. But to answer your question, no. I mean, there have been some of those, but they know the joint venture program. In fact, they know the rules. Don't turn the dirt because you have not been approved, and we have to have an agreement that's been finalized. And in fact, just yesterday we finalized a major one with the Cherokee Nation about they're doing a complete redo of the Hastings Hospital and expanding it rather significantly. For the people in that part of the country.
Okay. 2 years ago, Congress directed IHS to fully fund contract support costs. In order to do that, IHS took money from the direct operations. Direct operations had funded some dental positions at headquarters. They need positions filled, but the funding would now come out of the dental program. It's kind of a rob Peter to pay Paul situation. This year, direct operations received a $2 million decrease. I'm aware that there are several dental positions at headquarters that are vacant. Are there still vacancies, and how many and how long have they been vacant? Will the salaries come out of the dental program line? Are any of these vacancies because of funding changes due to contract support obligations? And did meeting the contract support costs requirement affect leadership hiring?
Okay, on the contract support cost area, 14 was a watershed year for, as you pointed out. That year, we projected, and we wound up having to find some discretionary side of the house to be able to meet our full obligation. And then in 15, we were able to kind of right the ship a bit. So we're in 16, the president's budget had proposed a mandatory account, or at least full funding, and I think that you all responded by a law that said we would have a third account with indefinite funding, and so we're moving down that. So for all intents and purposes, we have moved contract support costs into a third account, and even though our proposal for 17 is saying we still would like it over in mandatory because the Supreme Court has made it real clear. We're to pay 100%, and so we're paying 100% of all of our obligations under contract support costs, so that it will not now be a matter of finding the money on the discretionary side or taking it away from direct service programs. So that's that. I feel confident in the future. That's in a good place. In fact, I know that Deputy Director Smith has been working and providing leadership to the contract support costs work group. So we're going to actually have a policy in place that's been revised since 2001, updated in 2006, and now because of the court case, we need to reissue that policy and then put everything in a place where there's a agreed upon policy, and I think we're real close to a final version. In fact, it was a hard lift. I think we've had a contract support costs work group working on this since 2010, and now we're beginning to see where it's going to put that in a proper location, and the fact that we will continue to meet our obligations in 100% without adversely affecting the rest of the budget.
What about the dental?
The dental aspect of it, we have some vacancies, but the director of the oral health division is filling those positions, is not being told otherwise. He is not constrained because we went into a freeze in order to meet our obligations, included dental. But now he's been given the green light to go ahead and fill his positions. Okay. And it's going to be a challenge around the country, but it's not the same. It's a challenge similar to other healthcare professionals. Dental is a challenge in many of our locations. We do have some dental vacancies. And again, with your support, we have increased the numbers of loan repayment programs that would help us fill those positions.
Okay. Thank you.
Thank you. Mr. Kilmer.
Thank you, Chairman, and thanks for being with us. I guess the good part of going last is a lot of the stuff I wanted to ask about has been talked about, from mental health to opioids. I want to talk about something that hasn't been. I represent an area that has a lot of rural and coastal tribes, and they face some unique challenges. The conversation around telemedicine, I think, is valuable when you're geographically isolated, but is less helpful if you don't have access to high-speed internet. And the conversation around being able to provide care in your community is often challenged if your care facility, which is the case in one of the tribes I represent, where your care facility, which also serves as your emergency response center, is right in the path of the tsunami zone. So I guess my question is, when IHS looks at those sorts of challenges, what do we do for those remote, geographically isolated tribes in terms of being able to provide health care in those communities, and how can we as members of Congress help?
That's an excellent question, Congressman Kilmer. It's interesting. I'm sort of reflecting on when your question was going, how did we discover penicillin? And the notion is that we were faced with a challenge, and I think in the case of telemedicine, we're facing in right now a real challenge of ensuring that we can provide quality access to very remote locations. We've got some great models, and Alaska is a great model insofar as that telemedicine. For them to travel anyone is between $10,000 and $15,000 a one-way trip. So there's the need to have it certainly available. Our recent, and certainly going back to Great Plains area, is that we're looking at stationing telemedicine staff in some of the remote locations, and how do we go about doing that? Bandwidth is a big issue. Clearly, I mean, because if you're talking about simply having communication and access, it's one thing. But if you're going to move large files, X-ray files and such across that, you're going to really be challenged on bandwidth. And some of our isolated locations in the country become a real issue. But we're working with our fellow agencies about how to begin to address the bandwidth, if you will, that would surprise. And of course, the other part of it too is telemedicine. You've got to have both ends. You've got to have the folks at the other end that is available to manage the patients coming into the center, whether it's behavioral health, which is even more so. Or whether it's medical. We do a really great retinopathy program that we're doing by telemedicine. We're able to do reads, and I was in Elko, Nevada, and had my eye checked, and I was being told it was being read in Phoenix. And so that's those kinds of abilities. And I think as a system, it's my view that we need the tool that we can use in the absence of having a full staff out there. In some places, you don't merit having, let's say, for example, an optometrist in the community because it's too small. But you can certainly have telehealth available for that community. And that's where we're going to go. So I think from an agency stance, we're doing that across the country. And first it was by urgency, and now now we have a design to move ahead.
I'd certainly love to follow up with you and your team on how you work with those other agencies on making telemedicine a reality. I also think we've got to figure out how to make sure care facilities don't end up in the path of tsunami if you're a coastal tribe. I think that's a real problem. I also wanted to just follow up on one of the issues that Ms. Pingree mentioned with the opioid abuse, and you touched on the naloxone kind of availability. Can you give us a sense of whether there's adequate resources available to have that deployed and to have law enforcement trained? I know that that's looked at as a potential resource to at least avoid fatalities associated with overdose. So I'm just curious whether the IHS has adequate funding to roll that out.
We haven't been adversely affected to move ahead, and we've been using certainly our prime vendor, which is a special agreement we have with VA on making available the naloxone for purposes of deploying it, and our relationship with the BIA, with the Bureau and the law enforcement, for example, and the tribal law enforcement people is such that I think that if we start to project that we're going to be adversely affected by that, but otherwise we're making it available.
Are the communities that ask for it getting it?
Right.
No one's being told no.
No one's being told no at this point. And it's a supply that's available if it grows I guess in demand, we'll have to address that as well.
Okay. Thank you, Chairman.
Thank you. Just another question here. The federal government funds many of the healthcare programs for which American Indians and Alaskan Indians are eligible to receive services free of charge. Full enrollment in these programs can stretch limited appropriations to the Indian Health Service much further. Could you update the Committee on Indian Health Services efforts to achieve full enrollment of the eligible service population in these programs and other programs?
Not so certain I understand your question, Mr. Chairman.
Well, this is on to enroll, to encourage people to enroll for Medicare, Medicaid programs.
Oh, okay. Coming through our system, we have the benefits offices. Certainly, as a patient comes into a given center, the first place they're going to go is patient registration, which then begins to tease out what are they eligible for? Are they eligible for Medicare? Are they eligible for Medicaid? Or do they have private insurance? And if they are eligible for Medicaid, we get them enrolled. It's interesting. It's a voluntary system for us. We're doing. I think we translate the importance of the ability to bill Medicaid and Medicare for them, because we can turn that into additional services that we can provide by that given facility. Because, as you know, the law that was authorized in 2010 said all collections will return to the facility which generated them, and so there's certainly an incentive to have them get enrolled. I mean, there was a time that tribal people would push back and say, "Wait a minute, don't you have a trust responsibility to us? Why do you make me sign up for this other?" And when we explain to them how important it is, then we've seen the numbers go up. Have we maximized? I don't believe we've maximized. And clearly, it depends on, of course, it gets into whether the state has expanded Medicaid. But I think in any case, we want to make sure we maximize their availability. And if they're veterans, then we will sign them up and we'll bill VA for their services.
Well, it certainly helps us on our appropriations process if we're able to move that across. But so I certainly would encourage that, because we have our challenges just because of trying to increase the appropriations this year, as you're aware, just to keep up, just to stay even with the increased costs in healthcare in Indian country. So anything that we can do to offset some of this is certainly important.
Give a thought.
Oh, no, yeah, yes, Mr. Chairman, I think we have been working a lot more closely with CMS to try to see if we can think of some creative things to have like easier eligibility for both programs, and working more collaboratively with CMS. So I think we're making strides in that area, and we're going to continue doing that.
Okay, good.
Yeah, let me just add to that. That's an important point, Mary, and that was that we've added another person to our senior staff, who is her job is Deputy Director of Quality Care, but she has a vast experience with CMS, and she brings up these new ideas. And for example, the new idea was just recently, I hadn't heard of this, but auto enrollment. Yeah. Actually, when patients come in, we can get them enrolled automatically. So, I mean, that will expedite and expand our ability to ensure that as many people as possible are covered, and therefore we'll be able to generate some additional resources for those clinics, and that maybe take a little load off you.
Right. Thank you. Ms. Pingree.
Thank you, Mr. Chair. And again, I appreciate your being here today. And just one brief question here about, and maybe you've talked a little bit about this, but I don't think so, about the coordination with SAMHSA as I understand, in 2014, they created an Office of Tribal Affairs. And I'm just curious about how you work with them. You know, we've talked a lot about behavioral health issues and how the collaboration with them works. Are they informed by the Indian Health Service and you informed by them, and just what that relationship is like and how you benefit from it?
That's an excellent question. And the reason why I'm sort of happy about the question is that we've had a consolidation, if you will, in Rockville. So SAMHSA now, and we've moved into the park, the 5600 Fisher's Lane, and so is SAMHSA. So they're just in the building.
Great.
And so it's made our coordination a whole lot easier. But even in before that, we have been working together with SAMHSA on their community, and we've traded many efforts, if you will. We've got a grant going out. We let them know. They've got a grant going out. They let us know. And if there's an outbreak somewhere, Kana over at Enomoto over at SAMHSA is quick to call us. If there's a tribe out there that reaches up through SAMHSA, we get a call. I mean, just recently, a tribe out in California had a series of suicides. So, I mean, there's in more growing collaboration between SAMHSA and the Indian Health Service as it pertains to what SAMHSA can do versus what we can do. And then we collaborate. And I think going back to the example of, I think there was a question raised about coordination. I thought we were coordinating well, but it turned out that we had a couple of sites out in one of the reservations that weren't coordinating at all. They funded a clinic and a program, and we're funding a clinic, and the two folks across town, a small community, hadn't talked. And so we corrected that. When you talk to your grantee and I'll talk to our folks, and we'll get that coordination. So we're having more of that coordination on the ground, which it's so easy for us to say, well, they're in the same building and they're, but no, to answer your question on point is it's increased and will continue to increase as we begin to look at what they're being funded for versus what we're funded for. And the major distinction is we're a healthcare system. And so we're delivering care, whereas they're delivering funds to the community to develop the community capacity. And so for us, still again, to work together as we bring about maximizing our efforts.
Good. That's good to hear. Thank you.
Thank you. Mr. Simpson.
More than 5 years ago, IHS decided to take a different approach to early childhood caries, a childhood epidemic in Indian country. They recruited and trained healthcare workers beyond the dental program to work with kids and families on how to recognize and prevent disease. Working with 1 to 5-year-olds was the first step in addressing oral disease. Now the program has been launched and they are ready to move on to other oral disease categories. Early childhood caries was the dental program's first 5-year initiative. What will follow that?
I think on point, oh, I'm sorry. I thought it was on. Thank you. Certainly the Dr. Lozon and company at IHS headquarters is in fact continuing the initiative through the next 2 years, and clearly as conducting the ECC sites again. So we haven't lost track of the fact that the kids, the early childhood caries is still a very live program. I mean, we have not stopped that. And just yesterday, Dr. Lozon, I asked him, where's our program? And he says, no, it's we're expanding it. So
Okay.
We're going to continue.
I want to ask a question that I probably shouldn't ask, because somebody will say, what are you thinking? There used to be a saying around here 5 or 6 or 7 or 8 years ago in Indian country, don't get sick after June, because all the money ran out. And of course, that's something that this committee concentrated on, trying to provide the funding so that we got all these contract support costs and so forth at a level where health care was available. Now the saying is kind of don't get don't get sick after September. So we're moving along in the right direction. What is your authority to transfer funds within accounts to meet issues that come up, like if you run out of money for contract support costs? Can you move money between accounts? And the reason I ask this is the Forest Service has the ability that when they have catastrophic wildfires going on out there, they can take funds out of different accounts to make sure that they fight those wildfires. Now, we don't like that in this committee. Can you do that type of thing, or do you have to go through reprogramming processes, or what?
We have certainly an authority up to, let me check, it's up to $1 million? Up to $1 million to move between budget activities. Anything more than that, then we come in for your clearance.
For reprogramming?
Yeah, for under reprogramming.
Is that an appropriate level, or should it be more?
No, we can get back to you on that. I think so far it hasn't affected us. But getting your other question that you raised, Congressman.
Well, before you answer, and the challenge obviously is that when you look at healthcare services, when you look at less important programs versus trying to transfer money out of those, there are no less important programs oftentimes, If you look at the Forest Service, they can look at, well, we're not going to do trail maintenance this year and nobody dies from it. So it's a different challenge that you face. But if you could move money between less, I hate to say less important, but less critical programs to more critical ones when they run out of funds, would the $1 million be sufficient, or would increased authority in that arena be advantageous?
Yeah, I think increased authority wouldn't hurt. But I think that there's two ways to answer this question. One is 60% of our program is contracted by tribes. Tribes have the legal authority to redesign. They can move money around. On the direct side, because we're running the directs certainly on our side, then we're looking at the accounts. And I think the one you raised at the outset is that no, it's no longer June and it's no longer September. We got through and what you're most likely talking about is a catastrophic emergency health fund. And that's the one that was running out of money because of the numbers of large cases. We're going to have to look a little bit because we're getting ready to publish, and I think we haven't published it yet. The reauthorization enabled us to reduce the threshold to 19,000 instead of 25,000, and that may have an effect on the numbers of high cost cases coming in, which means that we'll have to take another look at it. But because of that, we've asked for a $3 million increase in our chef account for 2017. Just if we implement that change in threshold, then you may hear that again, but I don't think so. Okay. I think we're okay, but I think the authority to move money around in a health system is always an item. But I think that on our side, certainly, we can talk with folks as to whether or not that's something we want to propose.
Thank you for being here today, and thanks for the work you do. It is, as you can tell, for this committee, very vitally important that we address not only the healthcare needs, but the other needs in Indian country, and we do have a trust responsibility this committee takes very seriously. So thank you for what you do.
Just to clarify on Mr. Simpson's question, when we're talking about moving funds, we're not just talking about moving funds within the health service. Can you move funds from outside of the health service within the Bureau's accounts? I think maybe that's what he's also asking. Have you ever moved money outside of your particular line, out of the Indian Health Service account?
we clearly have always had two accounts, and then of course with the addition of contract support cost, and the whole distinction is we wouldn't move any money from the services budget into the facilities budget, or conversely.
Okay.
I mean, those are walled off, and we do not. We would reprogram within, for example, the sub activities like dental to agency, and conversely. But again, very limited. Folks are pretty jealous about this. Is let's talk if you're talking about trying to move money from this category to this category. Or there's some sub activity.
Just want to clarify that.
Yeah.
Thank you. Well, thank you for your attendance today. We appreciate your coming to our hearing. We wish you well. You have a big challenge ahead of you. We'll try to work with you the best we can to help you meet those challenges. With that, if there's no further questions, we're adjourned.
Thank you.